Well, we hope that you all had a wonderful Thanksgiving with family and friends, and maybe this isn't the best time to talk about the subject of obesity during this holiday season, but we are going to do our best to do so. So first of all, good afternoon. My name is Alyssa Hasty, and I'm a professor of molecular physiology and biophysics at Vanderbilt University. My laboratory is generally interested in how obesity increases risk of diseases like diabetes, cardiovascular disease, and cancer. And we focus on the immune system, which is actually hyperactivated in obesity. And we think this is particularly partially responsible for obesity-accelerated diseases. Today, our event is hosted by the School of Medicine Basic Sciences at Vanderbilt University as part of a monthly series called Lab to Table Conversations. To give you an idea of our event, today we are excited to have with us experts in the biology and clinical impact of obesity on health. As I mentioned, obesity is a well-known risk factor for diseases such as heart disease, cancer, and diabetes. However, it's often considered to be a risk factor brought on by choice or by inaction. Our discussion today is timely in that recently some of the world's top researchers who study obesity gathered to discuss the causes of obesity. And in fact, even among this group, there was no consensus as to what causes obesity. Topics such as genetics, macronutrients, gut microbiota, environmental toxins, and others were discussed. However, there was among this elite group the implicit understanding that obesity is not a personal failing. As opposed to that 3-day meeting, we only have 1 hour, but we'll do our best. We're excited to discuss some of what scientists and physicians have learned about mechanisms of how obesity impacts the body, the biological components to why certain individuals struggle more with weight gain and weight loss, and clinical and community interventions, among other topics. So for a little bit of housekeeping, first of all, if you have any questions, please place them in the Q&A at the bottom of your screen. We also received numerous questions from registration that we will attempt to answer at the end of our moderated discussion. So I first want to turn over the conversation for our panelists to introduce themselves. Let's see, Dr. Owen McGinnis, would you go first?
Yes, I'm Owen McGinnis. I am professor in molecular physiology and biophysics at Vanderbilt University. My area of interest is how inflammation affects metabolism, and use approaches to understand how that affects disease risk.
Great. And next we'll have Dr. Sherry Barkin.
Hi, good afternoon, everybody. I am the professor of pediatrics, the chair of pediatrics and physician-in-chief at the Children's Hospital of Richmond at Virginia Commonwealth University. And my research really looks at the complex interaction between epigenetics, behavior, and environment as it moves in time, looking at a life course approach, recognizing that obesity often behaves as a common chronic disease.
Great.
Happy to be here.
Dr. Gitanjali Srivastava.
Yeah, good afternoon, everyone. It's a pleasure to be here. I am Gitanjali Srivastav, and I lead and direct the Vanderbilt obesity medicine infrastructure here, including the medical weight management program. I'm the associate professor of medicine, pediatrics, and surgery. We also have an obesity medicine fellowship program that I lead and direct. So it is an absolute pleasure to be here with you all today.
Great. Well, thank you to the three of you for joining us. And just for the audience to know, we're all friends. And so even though we are all scientists and physicians, one or the other, we'll probably call each other by our first name throughout this conversation, just to make it a little more casual. So let's start with our first question that I'll address to you, Geet, which is, how is obesity defined? And what are the concerns or problems with a simplistic definition of BMI?
That's an excellent question and a great discussion to spark. So first of all, there are biomarkers. We can measure excess adiposity by biomarkers such as body mass index, maybe waist circumference, maybe the amount of visceral versus subcutaneous adiposity, but it really does not define obesity. When we look at the scientific definition of obesity, it's really a dysregulation of the metabolism that occurs and a resettling of the weight set point. And another analogy that I like to explain is, for instance, when you explain to a patient that you have a diagnosis of type 2 diabetes, you're explaining to the patient that they have a dysregulation in terms of how their body metabolizes glucose. But, in terms of high or low glucose, it doesn't really define diabetes. So there's more in depth in terms of the definition. And the reason that it also makes it very complicated to treat and challenging is that the etiology is complex, right? There is biological, epigenetic influences of the environment, behavior, psychosocial. There's the obesogenic environment as well. And so we have to factor into all of that equation to recognize and treat the disease, which also makes it very challenging as well.
Great, thank you. And Sherry, there has been an increase in the prevalence of obesity in the past few decades. What types of things are contributing to this increased risk of obesity?
Sure. Well, I wanted to just build on what Geet was saying first. When we look at children, and I'm the pediatric representative on this panel, when we look at children, you have to understand that height and weight velocities are different at different times, and that's normal for how children grow. So when you're a baby, your height and your weight might be growing around the same velocity. But then when you go through this preschool period, what happens is that your weight is intended to stay kind of steady and your height shoots up. Just imagine a tulip in the springtime. That's called saltatory growth, and that's normal. So if you look at a growth curve for a child, it looks like it dips down. It has a U-shaped curve. And if you follow that U-shaped curve, it's associated with better health outcomes. Then what happens is somewhere around 4 to 7, you emerge back into more of a parallel growth with weight and height growing around the same time. And then once you've hit after puberty, you sort of level out, because you're done with your growth velocity and now you level out on your weight. This ends up being really important when we try to understand what's really going on with obesity for children. And how do you understand it? Looking at things that happen during pregnancy, in early childhood, elementary school, and adolescence. So it's a really dynamic process. And we see obesity in children behave very much like a common chronic disease. So if you have a very high weight velocity where you gained a lot of weight in your first 6 months of life, you actually are more likely to be overweight as a preschooler and a toddler. If you're overweight or especially obese as a toddler, you have about a 5 times likelihood of staying that way into elementary school. And then it continues on throughout adolescence and adulthood. So that's important to understand for your question. That doesn't look like one thing. Not one thing causes it. And I think in your introduction, which was very well stated, the reason why we can't find a cause for obesity is that the question is wrong. It's what are all the contributors? What is the timing of those contributors? And the degree of exposure to those contributors that then result in the manifestation of obesity. And the only reason why we talk about that is because it's then associated with your health and the likelihood of going on to having a more of a disease condition with all of the consequences that you've mentioned of heart disease, diabetes, high blood pressure, and many types of cancer. So when we look at contributors, we have to understand that, of course, it depends on your food, but it's not only the amount of calories, it's the type of food that you eat and where your food is sourced from. It depends on how physically active you are, absolutely. But it depends not only on how physically active are you, but what's your total physical activity? Maybe you're not moderately or vigorously physically active, but if you're up and walking, that changes your metabolism, which changes your weight gain over time. Depends on your muscle tone. It depends on your socialization and how you respond to norms. It depends on whether you were born vaginally or via C-section, or if you had a dog in the house, which affects your microbiome and that affects your metabolism. So I think we're asking the wrong question. It's not what's the cause of obesity, it's how do we understand all these contributors together over time.
Mm-hmm. We've talked a little bit about some of the diseases associated with obesity, but Owen, can you kind of comment again on some of those diseases and why obesity is thought to increase those risk for those diseases?
Yeah, so the way I'm going to kind of frame this is that, it is complicated. And as you said in your introduction, lay scientists really don't know why. But we have clues of why it's so hard to lose weight. All right. And I think the way you can kind of think about it is that simply losing weight means you eat less. I mean, that's the way we always think about it. However, our bodies are really designed to keep our weight stable. And unfortunately, we have control systems in our body that basically limit our intake, but also affect energy expenditure. And we have these hormone systems that talk to our brain that say, I'm hungry, I'm not hungry. All right. And unfortunately, those same hormones regulate metabolism as well. And so when you limit weight gain, all right, by causing weight loss, you actually kick in a system that says, I don't want to change. And that kind of gets ingrained. It makes it really, really hard. Then on top of it, what you burn every day, most of it is the total amount of calories per day. Most of it is just your body needing calories, not actually physically walking, just existing. And your lean body mass, with your muscle mass, burns a lot of those calories. And just imagine, if you lose weight, it's like getting a lighter backpack. And therefore, you have less muscle mass. And so you're always fighting this battle of trying to lose weight in a setting where, oh, my metabolic demand went down, not because I changed my exercise pattern, just because way less. And then on top of it, as Sherry talked about, external factors we really don't understand, layer on top of that stress, lack of sleep, and quality of food that we have access to, layers on top of that to regulate our endocrine environment that just amplifies that challenge.
Yeah. So Geet, what are some of the consequences of obesity that you see in your patients?
Absolutely. So obesity that we know is a root cause of many complications. It either worsens or causes or exacerbates the progression of weight-related medical conditions, like such as diabetes, heart disease, fatty liver, inflammation, and steatohepatitis. We see a lot of impact also on infertility, PCOS, joint aches and pain, osteoarthritis. So it affects every single organ system from head to toe, including the psychological aspects. That's another aspect of the disease. But when we take a look at also other entities like cancer, endocrinopathies, and uterine cancer and colon cancer. So every single organ system in the body is adversely affected. And so when you think about treating obesity, there's all of these downstream effects that we don't realize when we have a significant amount of weight that comes off. All of a sudden, we see improvement in metabolic derangements of patients coming to see us by the treatment of obesity. What happens oftentimes is that there's a lot of misconceptions and myths in society in terms of, what Dr. Barkin and Dr. Owen were talking about, the multifactorial etiology. And so you have to put all of those pieces of the puzzle together to synchronize and make your metabolism turn in the right direction to have a downward weight trajectory. And it really takes a sort of a comprehensive approach. But by treatment of obesity, even, when we take a look at clinically meaningful weight loss, is 3 to 5%. But now we're in a new era of 2022, where we have some great novel therapies that are out there that are able to achieve even more significant weight loss, which we'll get into a little bit later into the discussion about as well. So oftentimes we get really caught up in treating, let's say, the type 2 diabetes and all of the complications, or the heart disease and the fatty liver that's now progressing to cirrhosis, when we have to take a step back and take a look at the person in a comprehensive picture and say, okay, well, you know what? These are complications, but complications of what? These are complications of obesity. And we don't take a breather and do that. But once you treat the obesity, all of these complications and downstream effects are going to improve significantly. And so we see a lot of that in our clinical practices as well.
Great. And we do promise to come back to some of the new therapeutic options. But before we get to that, Sherry, I was wondering if you could speak to how obesity affects children differently than adults.
I think this is why I'm really drawn to understanding how we can intervene on obesity, because we know that as it behaves like a chronic disease, if you can intervene earlier, you can change your health not only in childhood, but into adulthood. So that means we don't actually think of it as just a point in time. Every child, every person is really a movie. So what have you been exposed to when you gestationally during pregnancy, the type of nutrition you're exposed to? That's really important for setting up how your organs will function once you're born. And then what you're exposed to earlier in infancy, for example, if you're breastfeeding and responding to your normal satiety set points to say, I'm not hungry anymore. In fact, infants are great at that. They can learn and actually change their hypothalamus by how they're eating in infancy. But if they're overeating and they're not paying attention to those cues, then what that does is it sets up your adiposity, and you know so much about this, and how your adiposity and your fat cells function, as well as how the rest of your body is functioning. So the reason why it's different in childhood is that at each phase, your body is learning how to respond to the environment. And it's either learning to respond by storing more fat, which then might lead to more problems, as Dr. Srivastava said, into childhood and adulthood, or it's learning actually how to maintain a really healthy set point. It's that way that makes childhood exceptionally important when we think about intervening and preventing obesity and the later consequences.
And when we think about, this is diving a little bit deeper into the science of things, but molecular mechanisms really by which, in particular, diabetes risk goes up with weight gain. Owen, could you speak to some of what scientists have discovered the past couple of decades on that?
Yeah, so this idea, thanks. So this is a really important thing, because diabetes increases, obesity increases your risk of diabetes, but doesn't mean you're going to get diabetes. But the risk goes up a lot. But what really goes up is your risk of disease in general, that we call that metabolic syndrome and associated diseases of hypertension. So you may not actually develop diabetes, but you have those comorbidities associated with obesity. But the way I kind of think about it is that as your adipose tissue expands, it creates an inflammatory event that then spills over and talks to the rest of your body. It talks to your brain and says, don't listen to those cues that normally would regulate what I'm going to eat and whether I'm hungry or not. It talks to the liver and says, handle lipid differently. It talks to your heart and says, don't work correctly. And your GI tract as well. And so you have this set place where this immune system creates a risk that affects your entire system. Now, if you think about it from a risk of diabetes, central for diabetes is maintaining your blood sugar normal. The critical hormone in that is insulin, which is made by the beta cells of the pancreas. And the beta cells of the pancreas respond to an insulin resistance that's created by this inflammatory event. So insulin resistance means I need more hormone to do the same work. The analogy would be if you woke up one morning and it was cold this morning and you opened all the windows of your house because it started getting warm out and then forgot when you went to bed, and you did that every night, all of a sudden you realize that your heated system's working overtime. And you go, well, the temperature in the house is fine, until you look at your electric bill at the end of this month and you realize you've been working overtime. Well, essentially your heat is working overtime, your beta cell's working overtime. And that working overtime leads to risk, because some of us, when that beta cell is working overtime, will fail, because it has to increase its capacity, just like the heating system, to maintain normal blood sugars. So we're trapped in this system. We're asking a system to work overtime because of insulin resistance. When you lose weight, you lose that insulin resistance. And interesting, insulin resistance is not pathophysiology. As Sherry talked about, we go through phases of life. Insulin resistance happens in puberty. Insulin resistance happens during pregnancy. I call that physiologic insulin resistance. It's what's supposed to happen, but it happens for short windows of time. And so the beta cells respond appropriately most of the time, and everything is just fine. Obesity is a chronic exposure. The beta cells are working over time for your lifetime, and therefore creates that risk.
Yeah.
How great is Dr. McGinnis? What a great description. I just wanted to underscore for everybody who's on the call that we really see obesity as an inflammatory problem. And then you heard very clearly that it's an immune dysregulation, an immune dysfunction. And I think that that shifts the way we understand it so that we can better intervene upon it.
Mm-hmm. And some of what my lab is interested in is actually that immune memory. So not even just like the immune cells that would fight an infection, but memory types of cells, and that your body can remember previous bouts of obesity, so that weight cycling or yo-yo dieting can actually be even worse for metabolism than even just kind of steady state obesity. And we think part of that may be related to the immune system as well. So there's an awful lot of immunology and physiology and endocrinology going into obesity and its diseases.
Sure. To that, I wanted to add just one more comment. I think it's really important for us to realize that obesity is not a temporary condition. So for instance, when you lose weight, it doesn't mean that your obesity is gone. You still have a history of obesity, just like you have a history of high blood pressure or type 2 diabetes that is controlled. You can have obesity that is controlled. You can have obesity that is in remission if you're not on any medications. You can have obesity that is properly treated, on therapies as well. So it's important for us to recognize that it is a chronic inflammatory medical condition. And that's why from birth till later in life, it requires serious attention. And to Dr. Barkin's point of view in terms of younger children, it's really important for us to also recognize that the earlier intervention is much better and much more effective. So in younger children, when we have patients and when we have specifically younger children that we say, okay, well, we're going to wait till they're a little bit older to develop these complications before treating. No, because earlier intervention is so much better. I think in children, there's this developmental plasticity where if you intervene earlier, their outcomes significantly improve into adolescent years and into adult years as well. So chronic inflammatory medical condition that you can treat, it can become in remission, it can be controlled, but it is, so if your body mass index, as an example, is 34, and I ask this question to, the community, even my fellows, let's say that if you have a patient who has a body mass index of 34, and then now that patient has been treated, whether it's through lifestyle therapies or through medications or through, maybe medical devices, and that patient's body mass index is 23, does the patient still have obesity? And the answer is yes. This patient still has a history of obesity that is controlled with therapy, or it could be in remission, if the patient is not on any therapies alone. But it's just an important concept to reiterate and for us to understand as well.
That memory is so important. One of our studies showed that even before children were noted to be obese based on their body mass index, we saw already there were signals for this dysregulation that was happening around the adipocyte inflammation for preschoolers. And is that memory from what they experienced perhaps when they were in gestation or when they were younger, or is it intergenerational? We don't know that, but we do know that there are signals that are molecular, and in this case, epigenetic, that might give us clues to that.
So why don't we go ahead and talk about some of the new therapeutics that you have talked about? It sounds like there's some really great options coming to the forefront, and I think you even maybe have a slide to show us to kind of walk us through what the different therapeutic options are.
Sure. And let's start through that. So I like to break it up into what we consider older generation versus newer generation. And I can say that now because in the last 2 years, there has been significant advancement in novel therapies and the efficacy of these medications. So when we think about, let's say, 2012 and 2014, when some of these medications became FDA approved, we have phentermine topiramate combination, naltrexone, bupropion, or what we consider Contrave. And a lot of these medications were able to achieve anywhere from about to 5 to 10%, depending on the clinical trial. And so that's what the armature that we have. And then recently, we've had semaglutide, which is one of the GLP-1 agonists. And let me go back a little bit and just kind of explain a little bit what the mechanism of these medications are. So we talked, Dr. Owen alluded to this as well, is that there's a dysregulation in the metabolism and the weight set point. So if your weight set point is not working, it's going to defend abnormally high metabolism or abnormally low metabolism. And so many of these medications work through the hypothalamus in our satiety and hunger centers as well. And that's how they help us lose weight in terms of cravings and hunger. And another important concept for us to understand is that it's the physiology that drives behavior, and not behavior driving physiology in some of these medications. So what I mean to say is that, for instance, if you're less hungry, or if you have more satiety, is because there's physiologic changes that are happening in your body that are causing your brain to act that way. And so a lot of these medications act through the hypothalamus and the satiety and hunger parts of the brain. So the older generation was able to achieve maybe 5 to 10%, and the newer generation, semaglutide, is now able to achieve 16.9% weight loss. And we have another medication out there. It's called tirzepatide. It's a combination of GIP plus GLP-1 agonist. And this is a dual incretin analog, and it's one of the gut peptide hormones. And this actually also has been a game changer in the sense that we are now able to achieve 22.5% weight loss. And these were the results of a recent clinical trial, SURMOUNT-1, that were released. So if you think, and this is particularly in the last, several months to a year. And so if you think about what that means, well, bariatric surgery like gastric bypass and sleeve gastrectomy is able to achieve 30 to 35% weight loss. And so now we're in a new era of obesity medicine where we are able to achieve over 20% weight loss. And so imagine what that means for your patients, in terms of improvement of fatty liver disease, infertility, and PCOS, and maybe remission in type 2 diabetes. But these are typically well tolerated, and the semaglutide and tirzepatide are both injectable agents. And so this is more of the novel therapies. The older therapies are more oral, and like phentermine topiramate, and naltrexone and bupropion. The more novel therapies in terms of the injectable agent have a preferential effect on patients with heart disease. And so this is really important for us. So if you think about patients that are coming with obesity, many of those patients may have high blood pressure or atrial fibrillation or some type of heart disease or heart conditions. And so we want to be able to prescribe a therapy that is safe and effective. And now we are there, and which is really, really exciting.
Yeah, it's really encouraging. When do you expect some of these might be available for any physician?
Sure. So semaglutide 2.4 milligrams, or Wegovy, is already FDA approved and it's available. And then tirzepatide actually has already gotten an FDA indication for the treatment of type 2 diabetes. And the company will be pursuing a FDA labeling for an obesity indication very soon. The SURMOUNT trials are still ongoing. And so when those are wrapped up, it should be getting an FDA indication for an obesity very soon. But the tirzepatide is available if you do have a history of type 2 diabetes. The same thing with semaglutide. Semaglutide has an indication for both diabetes and obesity. And so semaglutide 2 milligrams is actually FDA approved in patients with diabetes, and semaglutide 2.4 milligrams is FDA approved in patients with obesity, but the molecule is very similar. The dosing is just a little bit different for the two indications. And so we've had a lot of patients who've had success on these medications. And the older generation medications were good, but it's exciting that we're able to surpass the 10% mark and now even hit the 20% mark in terms of weight loss reduction.
Yeah.
Alyssa, I was going to sort of ask a comment, and really is that I notice on this line, we're not, if you go into the lay press, there's 1,000 more treatments that'll be on this list. Okay.
Absolutely,
So can, I was just thinking about, there's, I always think about, is really the way to think about this dieting, or is it about lifestyle? And this idea, diet, in my view, I view the word diet or dieting as a temporary intervention to make a change. Lifestyle is a long-term commitment to make a change. And so I'm wondering it from as a clinician, or as like, how do patients see interface this figure versus what they see in the lay press?
Yeah, no, absolutely. And I think this is a very important point that you brought up. And in terms of diet, even when I am actually advocating or communicating with my patients, we refrain from using the word diet, because all of that, when you look at the science of lifestyle therapies, it has really changed in the last couple of years. We used to think that it was this diet and that diet, or whether it was all of these fad diets, but the actual diet is probably the most healthy. We're moving away from the word diet, and it's really about healthy, unprocessed foods and sort of that comprehensive nutrition that's really important for all of us, and for a healthy lifestyle as well. And so when we think about that, that's actually probably the most naturalistic therapy to add on to your repertoire. And it's something that we underscore the importance of, especially when we talk about starting with first steps. So thank you so much for bringing up that comment, because it's really important. It used to be the case that there was a lot of science research that, maybe it's the high protein, low fat, or high, low carbohydrate diets. But now it's, when you look at the literature, the best diet is the diet that you're able to adhere to, that is healthy, that is long-term, that is sustainable. And, added to that is, as part of the healthy diet, I think it's really important that you add sleep and stress reduction to that, because we don't think about it, but that has such a significant contribution to how your metabolism reacts and how your body's weight trajectory goes in the direction. So when we're counseling patients, it's not just a healthy diet, but part of that healthy diet is, mindful eating, it's stress reduction, is going to sleep on the time, is detaching from the iPhones and iDevices and all of those things before bedtime, so you have a good sleep hygiene. And it's easier said than done, but in this obesogenic world and obesogenic society, it's much more difficult to do. So we have to add that, as in terms of adjunctive therapies. And to Dr. Owen's point, I agree. We shouldn't limit that slide to just whatever is the novel therapies. There's great new medical devices that are in the horizon, and new discoveries that are just recently made with novel therapies that are still in the phase 1 trials. So I think in the next 1 to 2 years, we will see more and more effective therapies. And we are very close to being in a world where we will now have therapies that are able to come very close to even bariatric surgery considerations in patients that have contraindications to bariatric surgery or insurance coverage issues and things like that. So it's an exciting time to be in this field. And I've seen the field evolved over more than a decade. And at that time, there were just very, very limited therapies. And those therapies that we had we were happy if you were able to achieve 5 to 7% weight loss from baseline. But now the new rule is, we want to achieve much more than 15% weight loss. And now we're getting into 20% and hitting well above 20%. So it's an exciting time to be in the field.
And I want to just briefly keep you in the hot seat a little bit longer, because there were 2 questions in the Q&A that tie back to this. So I want to get to them now. So one is whether these new drugs, whether there'll be non-injectable options for them. And the other is regarding the side effects of the semaglutide and tirzepatide.
Sure. So semaglutide has an oral version. And that's the only one that is available as an oral GLP-1 agonist. It is FDA approved just for diabetes indication, but it is in clinical trials at a higher dose. So for instance, it comes in 3 milligrams, 7 milligrams, and 14 milligrams. And it's not as potent as the injectable semaglutide, but in clinical trials, it is being studied for an obesity indication. But for patients that do have, let's say, needle phobia, and want to prefer to start with an oral route, I think it's perfectly fine if you have, particularly if you have prediabetes or insulin resistance or PCOS, and you meet one of those phenotypes in terms of the oral versions. The older medications like phentermine topiramate combination, naltrexone and bupropion are all oral, but they're not as efficacious compared to the injectable agents that we now have available.
And side effects of the newer drugs?
Yes, great question. So these medications are well tolerated, and the most common side effects are related to adverse gastrointestinal side effects. So nausea, a little bit of heartburn, maybe constipation, just because there is a delay in stomach emptying. But nausea and vomiting less so, but nausea and heartburn and reflux. And so typically these medications are started at a very low dose, and every month you actually have to titrate the dose upwards. So if you can actually, most patients tolerate the medications very well. And if you are experiencing those side effects and you can symptomatically treat with anti-nausea medications or kind of space out the injections on, and kind of overcome that 4 to 6 week period initially, patients tolerate it much better. But these medications start at a very, very low dose and then slowly graduate to the optimal dose, just so that there is better tolerability.
Okay, thank you. We'll give you a chance to get a sip of water. So Sherry, I wanted to ask you about health disparities that exist in obesity. And in particular, can you describe some of your community-driven work to address these disparities?
Sure. Well, we do see that there are disparities in those that have lower SES status. They are much more likely to have obesity. In fact, obesity is one of the most common visible forms of malnutrition around. So you might have calories, but if you have no nutrition in those calories, you're going to have obesity, as well as many of these other consequences that we talked about, like high blood pressure and diabetes and heart disease and cancer. And then we add to it what Dr. Srivastava was talking about, which is often, these are also the same populations who often have very high stress, and they might not be in the same sort of conditions that allow for them to have accessibility to healthy food or access to a place where they're going to get a solid sleep at night, and all of these things then interact. So the main disparities that we see are those of lower SES, and what that looks like, that starts so early in childhood. In the community studies that we've done, we've really looked at how we can intervene early so that we can take what is practical. If you have $10 in your pocket, how can you still ensure that your family is going to be fed? What does that look like pragmatically? So how do we build skills on that? You can see that there's some elements that really work there, but it still puts the onus back on the individual rather than the societal lens that we talked about before. So we've seen some great progress working in communities with community settings using a 2-generation lens, where we can improve the eating habits, physical activity, and sleep habits of whole families. And then it amplifies that effectiveness throughout the family. So everybody can improve in terms of their health. Now, they might not lose a lot of weight, but we do see that they improve in their health outcomes. And I think it's important for us to recognize that these things are connected, health and your weight, but they also exist in a way that if you are able to sustain healthy lifestyles that Dr. Srivastava talked about, you are able to improve health outcomes. So we've seen that if you create environments where it's easier to have access to healthier foods and more physical activity and safe environments for whole families, that you can improve outcomes over time.
Great, thank you. This is such important work. I'm glad that you and others are doing that.
Thank you.
Let's see. So what are some concrete steps that individuals who are struggling with obesity can take? And how do we move from seeing obesity through the lens of an individual's choice to a more complex lens? That's a complicated question, but Sherry, do you want to take a first stab at it?
Well, I'm a little bit focused on all of the questions that are coming in the inbox as well, and trying to see if we might be able to integrate some of those things. Some of the questions in coming through have to do with, well, if you change healthier lifestyles, does your body have memory for that, for those healthier lifestyles? So I'm going to answer your question and hopefully that one a little bit. And that is, I always look through the lens of childhood. You can create a memory for healthy lifestyles, especially if it's in the earliest phases of life. And that's because we're born as an adaptive species. We're not actually born fully formed, fully functioning. That's why a baby looks so different than an adolescent. We actually need to grow into our environment. So in those stages of life, when you look all the way at early childhood through adolescence, if you create a really strong foundation of healthy lifestyles, you're building healthier organs, you're building healthier metabolisms. The way that your body responds in terms of inflammation is different. So that if you were then exposed to something where you might have weight gain in adulthood, you have more of a buffer when you lose that weight to do better, if you have that stronger foundation. And it just is because you're building your organs, you're building your metabolism, you're building your memory. That's why addressing it so early is so important. I won't speak, I'm sure others on the panel will talk about, well, what about later? What if you've lost a lot of weight in adulthood, what does it mean to sustain it over time? I think that's important. And I want to get to the second part that you've talked about, Dr. Hasty, and that is, we look at this, everything we've just described as individual. So do I get surgery? Do I take medication? Do I eat healthier? Do I make sure that I include physical activity? We recognize that our behavior is very much shaped by our environment. So if I have easy access to healthy food that's affordable and tasty, then I'm going to purchase that. I'm working in a hospital. If I walk down the street, I've got a lot of options for chicken nuggets and pizza, and I have fewer options that make it easy for me to grab and go something that's really healthy for me. If I were to create an environment to make that simpler, then that changes my behavior. Likewise for physical activity, I moved from Nashville to Richmond not long ago, and I live in a place where there's a lot of walking. So I'm walking 5 miles a day, and it's just integrated into my life. So our systems and structures and environments shape our behaviors. And I think it's important for us to change our language as we strive to address obesity and its health consequences.
Yeah, so getting to some of the Q&A questions and back to you, Geet, some of them, these questions are focused on whether these drugs need to be taken for life. What if a patient stops? What is that? How does that impact their weight? How does that impact the other comorbidities like hypertension and diabetes? So can you comment?
Sure, yeah, absolutely. These are great questions, and I've kind of been perusing through them as well. So first of all, the first question is, can obesity ever be cured? And I think that goes back to our original statement that obesity is a chronic inflammatory medical condition. So if you have developed obesity and all of a sudden, let's say you're doing really, really well, and it can be controlled or you can be in remission, very similar to how we perceive cancer treatment. You still need surveillance. You still need close follow-up because weight regain can happen over time. As we get older with time, there's different things that our body can be exposed to. We can be exposed to stressors. There could be deaths in the family. There could be new diagnoses and illness and medical conditions. So it is a chronic condition. And I don't think that you can truly say that you can be cured of obesity. Just like, for instance, if you have a diagnosis of type 2 diabetes, can you totally be cured of a diagnosis of type 2 diabetes? So once we start to reframe our mind and consider obesity as a disease, very similar to how we perceive cardiovascular disease, high blood pressure, and the NASH and steatohepatitis, and we put our mindset on obesity as a disease, I think a lot of these questions are going to have a little bit more clarity as well. The other questions have to do with weight regain and what happens when you come off these medications. And so because in tune with the same concept is that these medications are intended to be long-term, very similar to high blood pressure. So for instance, an analogy that I often use to help you understand this concept is, let's say that you have discovered that your blood pressure is high. You go to the doctor's office. The doctor is going to talk to you about maybe, healthy diet, exercise, reducing the sodium content, and doing a couple things, and we'll have you come back into the office for the blood pressure recheck in maybe 2 or 3 months to see how you're doing. And let's say you do all of those things and you come back to the doctor's office in 2 or 3 months, but your blood pressure is still high. So you've done all of the basic changes, but your blood pressure is still high. And it has to do with your biology and genetics and genes that are expressed on and off. So you may be prescribed an antihypertensive or a blood pressure medication, right? But if I were to ask all of you that question, let's say you come back to the doctor's office and that blood pressure is now controlled. And you come up to me and I say, oh, you're doing so well, let's stop your blood pressure medication. All of you would be saying, no, if you stop my blood pressure medication, the blood pressure is going to go up, right? So the concept is very similar in terms of an obesity a diagnosis and as a disease process. It is a disease process. So once you start a medication and it is treating you and it's controlling you, it ends up being a lifelong chronic medication. Now, this is where the healthy lifestyle and exercise comes into place, and that's important too. When we talk about exercise, it may not help you lose as much weight initially, but it helps you in the weight maintenance phase. It's like putting money in a savings account that you're using your bucks for later. So for patients that are pursuing a healthy lifestyle, that are exercising, that have good sleep hygiene, and that are meditating and doing stress reduction, and let's say they get to the point that we want to, the obesity is controlled and the patient is requesting, can we taper down the medication? Can we do without the medication? We can try that and see how your body responds to that. But the person who is engaging in healthy behaviors is probably going to be able to maintain that weight long-term compared to someone who is not. So I think that's an important concept to get across. The other questions that came up is, what is the safety and efficacy of these medications long-term? In the clinical trials, they studied these medications for 72 weeks, particularly the newest trial in terms of tirzepatide. So these are actually FDA approved for chronic long-term weight management when you take a look at the FDA labeling. When we take a look at diabetes medications, so let me flip this question around. Suppose you came up to me and asked me, came up to me and we're having this discussion and you have a new diagnosis of type 2 diabetes. And I say, okay, well, we're going to start you on metformin. I don't think you're going to ask whether it's going to be long-term. I think it's understood that this medication is going to be long-term and you have a new diagnosis of type 2 diabetes because diabetes is already established as a disease in scientifically in the layman community. Everyone understands that. And this is where we fall behind because we don't understand that obesity is a disease similar to all of these chronic medical conditions. So going back to that analogy, it is a chronic medical condition, and these medications are FDA approved and they are studied long-term. In fact, there have been more recent trials that are going to come out, like the SELECT trial is looking actually specifically at semaglutide, and it's over 5 years, and looking at patients, in terms of heart outcomes and heart disease and the efficacy and safety of that population. So as we get into this new era, these trials are going to be longer and longer, and we will have more data long-term. We don't have comparisons between bariatric surgery, where we have significant long-term data compared to anti-obesity medications yet, but that is going to be in the horizon as we get into these more novel therapies that are able to approach, 20, 25, 30% weight loss in the near future. I think those are the main questions that have been coming up. Let me just take a look and see if there's other questions along that avenue. So there was another question that came up is, what is the lifestyle intervention while you are on or while you are prescribed an anti-obesity medication? And going back to that analogy, in the clinical trial setting, these patients actually had strict dietary modification. They were followed with dietitian and dietary counseling. But in the same setting, it's really important to have a healthy diet and have structured activity. So for instance, if you are going to be prescribed, let's say semaglutide 2.4 milligrams, but you're going out to McDonald's and Burger King and eating processed foods like every single day and having a very sedentary lifestyle, and your stressors are off the roof, and I see you back in 3 months and you tell me, oh, Dr. S, I haven't lost any weight. The system is very complicated. It works together. So you have to treat all of those, all of that piece of the puzzle. You have to address the biology, the genetics, all of these things have to come together as one piece of, or as a holistic piece of the puzzle to kind of turn your metabolism in the right direction.
Thank you. We have only about 8 minutes left, so we might seem like we're just skipping around a little bit, but I do want to hit on a couple of more questions in the Q&A. So Owen, maybe you can start on this and I can jump in as well, but there's a question about obesity impacting macrophages and T cells, the immune system in general, and what organs are particularly impacted by that.
So I kind of hint, thank you, Alyssa. So yeah, this is an interesting topic because the reality is the immune system affects every organ in the body. It's just that adipose tissue is inflammatory rich. And because that is the tissue that's expanding, the inflammatory events are happening or originating potentially there and then spilling over to the rest of the body. And, one of the comments was, well, do fat cells just disappear when I lose weight? Well, not really. Alyssa, probably you could speak more to that. But I think in general, the answer is they are there. All right. They are there. They're waiting to store calories when needed. And the immune systems are also there talking to them and going, hey, should I get active or not? All right. If you start expanding, I'm going to get more active. And then either way, I'm going to tell the rest of the body you're more active. And so that is the vicious cycle of the yo-yo that you talk about, right? It's the idea that if you have this expanding and contracting space, it's dynamically remodeling, and it's going to tell the whole rest of the body using the immune system that I'm remodeling. Do something about it. So.
Yeah. And so Sherry, there's another question on low socioeconomic status families, in particular food deserts, and how might someone from a low SES background combat the stress to reduce obesity, particularly if time and money are an issue?
Sure, thanks for that question. That's the research that I do, and what we have seen that makes a difference is the benefit of real community. So we worked with our parks and recreation in Nashville and Middle Tennessee, and we connected families together. We're a social species on purpose, so creating a strong sense of social support, not social media, but real social support where somebody can let your dog out or watch your child while you run out to the grocery store, that is something that really reduces stress, which reduces inflammation, which improves outcome. Another element that we found to be really helpful is that we really were working on building skills, and again, 2 generations at a time. So we were building skills like, how do you use your resources in your environment differently? If you have a backyard or a nearby park or parks and recreation or a library, how can you use those spaces to get to better health as a family together? And then we also built skills around healthy cooking together. And it sounds pretty straightforward, but we made it as simple as possible. We delivered groceries to your doorstep with ingredients, and you can buy those same groceries at Walmart. You can purchase them on Wick and Snap. And then we had 2-minute videos for you and your child to make them together. If you're somebody who doesn't have children in your life, it's just having a buddy. If you have one other social person in your life who's really supporting you fully and your health fully, then it becomes fun. And actually the children were teaching the parents how to cook healthy. And then you build skills that we were able to see reduced food insecurity by 25%. And that's without changing all the things that we know we'd like to change in our worlds and systems to ensure that people have economic security and access to good health and safe physical activity and safe places to sleep. All those things make a difference.
Yeah. It's encouraging to hear some of the work that you're doing, as well as the new therapies that are out there, and to also just think differently about obesity. We often talk and we are here talking about the metabolic consequences of obesity, but thinking about the positive ways that we can move forward, I think, is really encouraging. With the few minutes we have left, do any of you have any last things that you want to say to encourage our audience?
I just wanted to comment, because one of the questions in the Q&A was, what's happened over the past 30 years to see such a dramatic rise? And I hope that what you've heard throughout this hour is that this is a common chronic inflammatory condition. And so that makes us then say, what's different in our environment that has become so much more pro-inflammatory? Well, our food systems are different. The ingredients that you put in our foods, just take a look at the side of something, even a condiment that you have, and you have 20 ingredients. Many of those ingredients can affect your microbiome, can create a pro-inflammatory state. In fact, we've seen all kinds of things happen in the past 30 years that we'd never seen before, like eosinophilic esophagitis. Where did that come from? Why didn't we see that before? I suspect it's something similar. Food systems and ingredients that are not whole, real foods that are creating pro-inflammatory states. And likewise, as we become more and more of a society of convenience, we have these invisible environmental obesogens in packaging and the things that we're putting in the microwave and the bottle that we might be drinking from. So I think that we have created a more pro-inflammatory environment, and that's why we're seeing obesity as well as many other things rise.
Well, I just want to finish by thanking all of you for joining us as the audience, for listening, and for our panelists today. This discussion will be posted on YouTube shortly, and you'll receive an email with a link. In addition, a lot of the topics we've just talked about and that I mentioned in my introduction are published in a New York Times article. And so we'll include that link for you. And I think that'll give you some good food for thought, if you will, as you continue to think about this topic. But we just thank you again for joining us today. Have a great afternoon.
Thank you.
Thank you.
Thank you.